self-centered or conceited or anything, but what I'm trying to do is present some of the cases that I was involved with and how we got involved and what happened as far as the reporting end of it. I won't go into great detail about the cases, but obviously we'll have to cover some of the cases. I have no conflicts. So my plan is at the end of my talk that you'd be able to develop a plan to organize an approach to dealing with what you see and put things together to understand the legal and ethical ramifications of what you may encounter during your career. It shocks me a little bit how many times I was involved with some rather serious problems and how many problems are probably out there that have gone unnoticed by others and unrecognized and unreported. So just to give you a little background, growing up I had certain influences on my development. Dick Tracy was one of my favorite cartoon characters, and in the era where we didn't have television and cartoons, the Sunday papers had the cartoons and the comic books. Sinclair Lewis and A.J. Cronin are some of the authors that I read both in high school and college. And interestingly enough, when I entered medical school, I got a reading list of books, and their books were listed. I also read a play by Eric Ibsen called The Enemy of the People, An Enemy of the People, that talked with a Dr. Thomas Stockman that had an ethical and moral dilemma, and he became sort of my hero. As did Conrad Snyder, the hero of a television program called The Medic, and I learned a tremendous amount of medicine and toxicology from that. But probably the biggest influence was Bertrand Ruchet. His book, The 11 Blue Men, was on my reading list to medical school, and I still have a copy of that, plus the expanded version, The Medical Detectives. And I would hope that most of the people listening in have a copy of it or have at least read it themselves. My own book I'm not going to push, but it was my attempt to kind of have a modernized medical detectives. Louis Pasteur is said to have made this in a grand rounds that he gave. And that's kind of been part of my mantra. Be prepared for what you may see and know what to do with that new knowledge and what to do with it. Albert Szent-Györgyi was a researcher during my time in college and had this quote, which I thought was fascinating. And he made it about research, but it's also true. When you see a patient in front of you in the emergency room or tox clinic or a tox referral, realizing that that patient may be the first of an outbreak. That patient may not be simply one sick person. And you know, the other thing that I constantly used to tell students and residents is that patients don't come into you as multiple choice questions. You have to have an open mind, but it has to be prepared. And this one's closer to our era or our area of pharmacology, and that you need to know what to look for in order to be successful. So here are some learning thoughts. One is seize the moment. Carpe momentum. It's carpe diem officially, but I change it to carpe momentum. And the Boy Scout motto is always be prepared. Claude Bernard said, it is what we think we know that prevents us from learning, which leads to the concept of cognitive anchoring or inability to see beyond the immediate sight. It used to bother me in the emergency room when I'd go in, the nurse would say to me, this patient's got so-and-so. I said, please don't do that to me, because that way I'll only think about that as a possibility and won't have an open mind. So those are things that I keep in the background. So here's the first case. Some of you may know it. Perhaps it's my most famous case. Uh, but it started at a hospital in New Jersey where a 40-year-old woman was admitted. She had had cancer and had chemotherapy and had some myocardial injury from that and was on DIG. When in the hospital during the second day, she developed a significant bradycardia. A cardiologist came in and discontinued her digoxin, and she did very well afterwards. But 3 days later, she developed a repeat bradycardia. And they were puzzled by it. They did draw a dig level, and it was 9.94 nanograms. And remember, they had stopped the dig days earlier than that. The next day had dropped to 4, and then to 2, and she, did okay. They pulled stored blood from admission, and I must tell you that any number of times we were able to go to the lab and find bloods that were routinely kept in most of our hospitals for a week before they were discarded. We would go and grab the blood from days ago to be able to look toxicologically. Anyway, because of that level, one of the nurses was actually a nurse practitioner, called the Poison Center for help. Actually, I asked them to send some detailed information, and this was an email or letter, I don't remember, that we got from that nurse. And just to highlight the date because it's important in the context of what went on. But you saw that this is what she described as what they saw. And this was, the later on, and what they were asking was at that point, could it be this Korean tea that she liked to drink that might have something in it that was like a dig-like substance, which was a very interesting question. I knew nothing of any. I knew no mushroom that would actually have dig in it, but I did ask them to send me a sample of it, and actually Bob Hoffman helped with the analysis, and of course we found no dig in it. So she stopped taking that tea, and her level did drop off. And as I said, we did test the tea, and it had no dig. Well, 2 weeks later, a hospital pharmacist was calling in to discuss a patient with us, and actually got to speak to Bruce Ruck, that most of you probably know, worked as our managing director of the Poison Center. And this patient has been started on dig on day 6, and on day 13 the level is 1.59, and everything was fine. She developed an arrhythmia on day 15, and they found her dig level to be 9.61. She was given fab fragments, and she did okay. And the pharmacist was calling Bruce and speaking to him about the pharmacokinetics and what the heck could account for this. I happened to actually be walking by Bruce and said, I already spoke to them at that hospital. Is this another case, or is this the same case? And from that point on, we was kind of in the bind of what should we ask and what we should do next. And if we had time and this was interactive, I would ask you all, what would you ask that pharmacist at this point? I'll give you a second to think about that, but again, it's the inquisitiveness that I have that led me to jump to a conclusion that something was wrong. So we asked the pharmacist if there had been any strange occurrences in the hospital recently. And guess what? She claimed that told us that there were 2 patients in the same unit as the 2 dig patients that had developed severe hypoglycemia. And one of them actually had been seen by an endocrinologist who got them to draw insulin and C-peptide levels, and found a very high insulin level and no C-peptide level. And in fact, they actually got a urine that showed that there was no oral hypoglycemic agents. So now what? is this a reportable illness? What do you do at a time like this? You've got now 4 patients that may have been subjected to massive medical errors in the ICU or something worse. If you're thinking about either of those alternatives, what is your responsibility and who do you report to? And if I do call somebody, what am I at liberty to report? And what would be my legal responsibility either way, either to report or not to report? HIPAA is involved, confidentiality of the hospitals is involved, all of this. And what are the possible fallout events from reporting versus non-reporting? Our poison center's financial structure depended on contributions from the hospital to the general fund that allowed the poison center to function. So the fear was if we reported this to some legal authority, would the hospital then pull out and no longer support us and we'd go out of existence? And worse, would that hospital go to other hospitals and say, hey, these guys are not our friends? So it was really a conundrum. So going through my mind is, who do you report to? And these are the various choices that came to my mind. To report it to a local health department? Do we report it to a local police? Do we go to the county health department, etc.? I knew that adverse drug reactions in hospitals are supposed to be reported to the Joint Commission. So that was on my radar scope as well. I don't know how many of you that are listening have had experiences with contacting any of these agencies and the time involved and the kind of questions that they would involve you with. So think about it. What would you do? And this was the first time that I recall in my career in the poison center anyway, that I was faced with something like this. I do remember as a resident in Bellevue having a child in the emergency room that, according to the parents, had fallen off a bed and was in front of me in coma with obvious multiple trauma. And I knew that I had to report that one, and I was obligated under law to report it to DIFAS or whatever it was called at that point. So that was relatively easy. This one was a much more difficult decision, both on should I report and who to. This is the webpage for the New Jersey Department of Health, and it talks about how to report a disease, but it's based on communicable diseases. It doesn't deal with the concept of perhaps a severe med error or worse. However, if you look here, hopefully this works, yes. According to the regs, there's supposed to be an immediate call to the local health department in an outbreak of illness, which could be a nosocomial disease or an act of bioterrorism. To me, nosocomial means it occurs in the hospital. But again, if you look at it, these are all infectious diseases. And all of these reports are based on infectious diseases. Interestingly enough, there is a division of occupational safety that has reporting essentials. And most of that, except for a few chemicals, is also on an infectious disease. For those of you in New York, this is the New York State website that talks about reporting requirements and goes through what is a regulated facility, not a regulated facility. And also, if you click down where it says reportable condition, it'll take you to what should be reported. And take a look through it, and you'll see, again, it's infectious disease, except for this little captioned item here, that if there's unexpected morbidity and mortality, it does say associated with medical devices. But, I have to say I find myself generalizing this to say that under this rule, you probably are obligated to report a cluster of such bad cases. Well, what I did do is I called the chief medical officer and the chief executive officer and the MISC manager of the hospital, and we had 2 telephone conferences with them. And it got to the point I said, you really have to report this. And they said they would absolutely not. And they told me if I thought I needed to report it, then I should. And so what I did do is I called the emergency medical service director. Our funding actually comes through the EMS. And at the time, the state epidemiologist was in charge of that division. So I called his office. And he took the position that what I was describing was not a nosocomial outbreak. And the best that the state could do was doing a licensing investigation and taking a look at the licensure of the, the hospital and the laboratory. He did flippantly said, that he thought I was reading too many detective novels. So I did pen this email to the woman in charge of the licensing group, and I pointed out what I saw and what my suspicions, and asked her to go ahead to do a licensing investigation. And since it wasn't, that's what they did. They did a licensing review. I couldn't tell you exactly what that actually is, and not an epidemiological review. I am not privy to those results. In a book published about the situation called The Good Nurse, there is a footnote that describes the discussions at the State Board of Health, Department of Health, as far as what they should do with the information. And the Commissioner of Health's comments reported was that he thought that there was a perfectly logical medical explanation for what happened, and therefore he didn't think it needed to be reported to the Attorney General's office. But when I spoke to the department, I said, look, if you can't find something that's obviously an explanation for this, then you guys really have to report it to the Attorney General's office, or let me know what I should do. Well, the woman involved said they would, but never contacted me about doing such. And October 3rd, that's 3 months later, we did get a letter at the Poison Center from the Department of Health. It was then called the Department of Health and Senior Services. They requested a copy of all of our information that we had gathered, the chart and all. So we knew something was afoot. Then finally, law enforcement did get involved. And to be honest, I'm not 100% sure who finally tipped them off. But on October 27th, Bruce took a call from the transfer from one of the poison specialists that had detectives from the Somerset County Prosecutor's Office asking about DIDGE, to which Bruce said, do you mean the cases at the Somerset Medical Center? The detectives were rather startled, to say the least, and said, what do you know? And Bruce said, we have a whole dossier on the cases and our interaction with the hospital. And they said, well, can we meet? Well, we happened to be on the 5th floor of the hospital building that we were in, and the legal office was up on the 11th floor, I think it was. And Bruce asked me if we could go up, we meet these, and I said we better clear it with legal. And we went up there, and they said go ahead, but get a subpoena. And we told the detectives, and even with getting the subpoena, they were on site with us within an incredibly short period of time. We were involved in the background with the prosecutor's office, looking over cases and helping them sort out what was going on. And we were as startled as everybody else was when on December 12th, the news broke that said that a nurse had been arrested. I don't know how that little red thing is doing that, but that's weird. But anyhow, that's when it became public knowledge. And I actually got this from the Department of Health a couple of days later that said they were bogged down, busy as heck, and that it was my um, initial call that started the ball rolling and kind of thanked me. Actually, the state epidemiologist became very incensed on the way the hospital was treating us once this broke into the news. Eventually, Charles Cullen, who was the nurse that we were finally able to identify, claimed to have killed up to 40 people, and he's in Trenton State Prison, and will be there for something like 200 lifetimes. He only was willing to plead to the 32 or so murders, and actually they had me meet with him to discuss which cases he would be willing to admit to. And his comment was that he didn't want to make his family think that, or his family be stigmatized by having an evil person, and therefore probably close to 100 or 200 cases that I thought that he was involved with, he would not plead to. Um, he was, as I say, sentenced to 18 consecutive life sentences and non-parole. He was involved in some crazy shenanigans to donate a kidney, but he's in jail for the rest of his life. Interestingly enough, people came out of the woodwork once the case was exposed and showed the prior missed opportunities. And the reason that for this discussion is that there were several times in the past where some person could have picked up on what was going on, reported it, and stopped him from his killing spree. This was several years before. And this was a note from a cardiologist reviewing the chart of a person that had died. And he even wrote in here, unfortunately, brings up the question of dig toxicity, but doesn't explain why his level rose. Well, I think we know now. The manufacturer's rep from whichever FAB antidote they used called Bruce sometime after the news hit, and she said she had always wondered why this smallish hospital used more fab fragment than any other hospital. Another opportunity that could have caused an intervention and prevented deaths. The lab technologists, uh, they they should have paid attention to it. There was obviously a matched or mismatch between the diagnosis and the results that they were seeing, and perhaps they did bring it to somebody's attention. We don't know about it, but the question comes up: if you're a lab technologist, what is your obligation when you pick up something like this? And the pharmacists, they were refilling the Pyxis with all this dig, and why nobody put two and two together, particularly after so many dig overdoses occurred within the hospital. Uh, Again, this was obviously either unprepared minds or people kind of saying, well, this can't be happening. So how do you solve this case and other cases? And I'll show you a couple more to show how this works. Is first, you have to have the knowledge. You have to know about dig toxicity. Uh, we had this discussion about high potassium levels versus low potassium levels and acute dig toxicity versus chronic. That helped, certainly helped in the delineation of cases that he was involved with after he was already charged with attempted murders and murders. Interestingly enough, he became so knowledgeable that when they had him review cases after he was already in jail, there was one case that he said he couldn't have been involved with and it couldn't have been ditched because the potassium wasn't high, and that Marcus told him that you had to have a high potassium level. The intellectual curiosity, I don't think I'm unique in that, but you've got to let it fly. You've got to not just stop at the obvious. You've got to dig into the situation that you're involved in, be inquisitive. You have to be compulsive. My wife has always hated me for that. And I guess my staff probably as well, because I'm compulsive. I'm like a bulldog. And you have to be that way. If you've got a case that you're scratching your head on, don't give up on it. You can put it away for a day or two or even months. One of the cases, I don't know whether I'll get to today, it took me 6 months before I actually put it all together. So you have to be compulsive. I actually still have some undiagnosed cases in my files. You also have to have confidence so that you don't let anybody push you around. You have to have the grit. I was threatened with all sorts of things by the hospital over my reporting of this case. I was called a bad guy, and they wrote to the state and wanted me censured, etc. So I really had to be confident in what I did and have the grit to stand up to it. Okay, let me pause for a second, and I will now talk about another case. Some of you may remember all of these cases because I have presented them, but not from the aspect of the legal portion of it. But anyhow, this one was how important it is to listen carefully to the patient, because sometimes a patient that comes in saying somebody's trying to kill him, he or she may be correct. So this was a case of an Asian man, a software engineer with no exposure to any serious toxins, that after having a meal of rice and beans, he developed abdominal pain, brown diarrheal stools, nausea, and vomiting, and went to the emergency room. He had his son had been hospitalized 2 weeks prior to it for diarrhea and dehydration. So there's a little complication there, making you think maybe there was some infection or something else. This was his labs and physical examination emergency room, and really essentially nothing there. He had some mild abdominal pain and stuff. He had ultrasound, which was normal. He had a CT scan, which really didn't show anything that would be responsible for any of this. So he was admitted, and the next morning he was describing pins and needles paresthesias, and that he said that around Thanksgiving he got sick after a meal and had some similar complaints. And he told the staff that he really think his wife was poisoning him, and it was well documented in the chart that he had told them this. He had increasing paresthesias. When I talked about him having allodynia, one of our astute neurologists at one of the tox consultant meetings said that, that made the diagnosis of the toxin immediately, because he'd only seen that with that particular poison. But he was in such pain he would move his legs. And all of this was well documented in the chart. On day 3, a pain consultant was called, and this was his comment. I won't belabor the issue, but he actually documented in the chart again that the patient thought that his wife was trying to kill him. But his final impression was, as you see, no comment about the possible homicide or attempted homicide. Seen by a psychiatrist who said, well, he's acting paranoid, but maybe somebody needs to exclude the possibility of a poison. So neurology said, well, let's get a urine for heavy metals, and the urine came back negative for arsenic, lead, and mercury. Uh, Hopefully, somebody out there is thinking, or that they may be missing a few other metals. Anyhow, he was transferred to the ICU, and an ICU nurse said she just read in a Chinese newspaper of a family involved with a similar kind of case in China. And although, you know, that may be a kind of a stereotype thing that all Chinese are Chinese, you know. But anyhow, she raised the issue, and the Chinese newspaper actually did have the toxin, and so they called the lab that still had the urine and put it as an add-on. This was actually the newspaper from around that time, and went into the discussion. So anyhow, the report from the special lab came back and found the thallium concentration of 800 micrograms per liter. It was at that point that the ICU physician called the poison center. We had not been called at any time prior to that, when the patient was complaining that he thought he was being poisoned by his wife and had symptoms. Whoops. So this was the call to the poison center, and it first came to the specialist, who then said, hold on to the doctor, and told me about the elevated thallium. Didn't tell me anything more. Didn't tell me that they knew that he claimed that his nurse was trying to kill him. But so she reviewed the elevated levels, and I said, get the doc on the phone with me right away. And before I let him go any further, I said, given the lab results, you've got to call the county prosecutor's office immediately. I chose the county prosecutor's office because I learned after the Cullen thing is that if it's a if it doesn't involve a fatality, then it's generally the local police. But if there is a fatality at all, it should be the county that gets involved. Well, to me, when I heard the story of this guy and that he was deteriorating, I felt it was close enough to a fatality that we should go for broke and go to the prosecutor's office. And I told them that I would really, I would respect them, but if they don't agree to report it to the prosecutor's office, then there's no point in us discussing it further. So I said, as soon as we get off of the phone, you must call the prosecutor's office. And we discussed getting a hold of Prussian blue and what to do in the meantime. It was kind of an interesting situation, because it was the night before a blizzard, and the following day it did blizzard, and trying to get Prussian blue into a hospital was not easy, although I was able to suggest to them that they go to the histology lab, because Prussian blue is used in certain histological preparations. And if we could convince the pharmacy to use it, we could start using that until we could get them some real therapeutic Prussian blue. But that's a whole other story. Despite what we did, and I actually managed to schlep out in the snow, had to dig my car out, and that's a whole other story, because my condo association hadn't plowed us yet. But I got there, and actually the first people that greeted me when I parked in the parking lot were three police officers that said, "Oh, are you Dr. Marcus?" And I said, how do you guess? And they said, "What other idiot would come out in a blizzard?" Anyhow, when I went out actually to see him, his wife was literally sitting at his bedside, and it turns out she had been feeding him soup from home his entire hospital stay. Again, missed opportunities to perhaps save his life. We tried everything, but he expired. His wife was tried and convicted of first-degree murder and sentenced to life in prison. Now, when we discussed the thallium with the police officers, and it turned out that there were local and county police officers there, they asked where the woman, where his wife could have obtained the thallium, and I said, beats me. You know, it's been decertified as a pesticide in the U.S., but I assumed that anything could be ordered from the internet. And I went on a computer and I found a company in I don't remember, it was in Philadelphia or New Jersey, that actually sold thallium, and I could have bought some and had it delivered by giving them my credit card. She had it delivered to her office. To her laboratory. She worked for a pharmaceutical company in New Jersey. When the police arrested her, they went to her locker and found a container that was supposed to have a certain amount of thallium, and it had thallium, but not the amount that was labeled. So clearly, she had used the thallium from that to kill him. Finally, I don't know if how many of you have been plagued by these telephone calls, but since my retirement and certainly since COVID, the number of telephone calls that I get, both on the house phone, my cell phone, etc., saying that you know, you're in danger of losing your car coverage. Um, this was kind of a variant on that, but Bruce called me. He was in the office and got a call from somebody claiming to be an officer of the DEA, claiming that my prescriptions were being used to prescribe a large number of opioids, and they wanted to talk to me about it. And so Bruce called me, and I said, "Thank you. As far as I know, I have a few prescriptions in my house, blank prescription pad, but I got rid of and destroyed every other one. And I don't know how anybody could be using my name or a prescription pad, but I would look into it." Well, luckily, Bruce and I had a very close relationship with Danielle Gilbride, who was the chief of the New Jersey DEA surveillance group. And I called her to say, "What's going on? Could this be real? What do I do now?" And she said, "You know, relax, hold on." And she checked and found the name that was given. Actually, it was the name of somebody that works for the DEA, but she was a clerk in the Westchester office, and the telephone number doesn't match. And when she called that particular person, that person said, that's not her. And that, in fact, that's not how they work. And the caller that spoke to Bruce said she had a particular DEA number, and apparently the DEA does not have such a number. So the DEA said they would take care of it. I don't know whether they caught this person or not. But in one of my medical blogs, I received this thing, and I'll let you read it if you want. But it was a report of some pathologist who panicked when he got a similar call, and it actually cost him, you know, thousands of dollars that he will probably never be able to recover because he got caught in this scam. The Both the state of New Jersey and the DEA are aware of this going on, and this actually came from the, the New Jersey Division of Consumer Affairs, warning everybody to be on the lookout for this scam. So again, this could affect you personally, and you need to be aware of it, be looking out for it, and not get duped. Maybe we can, I'll just go through this very, very quickly. Last month, there was a case presented of a peculiar lead case. This was a 13-month-old that had been studied by the pediatrician, had a lead of 57. They then called me. He was admitted to the hospital. The hospital did a repeat lead and said it was 28, and he was discharged. I said, that doesn't make sense to me. Let's redo the lead. We redid the lead in our lab, and it was actually 40 something or other, and he was readmitted. This started the investigation of the particular instrument that was used in the hospital, and that instrument actually subsequently was recalled. That instrument has had 3 recalls subsequent for problems. It was designed as a point of care instrument that hospitals were using as cheaper ways to measure lead. So that was the first aspect of getting involved with a paramedical situation. Anyhow, the home was inspected by the health department, and they said there was no lead. They went back and they said there was no lead again. And then again, I spoke to the health department and said, well, you've missed the source. That kid's body doesn't manufacture the source. His lead, the lead was treated in the hospital, dropped to 22, and a repeat home visit. Again, no source of lead, and they did a visual, they did this swab, dust swabs, etc. The pediatrician called me and said, hey, you know, the kid is being breastfed. The mother is of Indian descent, had traveled to India. Could it be in the breast milk? And could we do a breast milk lead? And I said, we probably could, but I didn't want to ruin the equipment that we had. So let's get the mother's blood, not just the breast milk. And the mother's lead level was 87. Turned out the family was not Hindu or Muslim. The mother was a homemaker. They lived in various parts of the country and was in India 4 months ago. But you know, that would be a lead that high and FEP that high. That's a considerable exposure. So there was this shaking of the head and scratching of the head thing. The health department tried to blame it on maybe she got it in other parts of the country, in India, occupation, you know, etc. I said, no, that doesn't make sense. We got the father, his lead was 95. He had no known exposure. Again, there has to be some common exposure. So here I had to be the bulldog again, to be the bad guy and say, you better go back out there. There's got to be lead in that house. Send the health department back. And luckily, we had the money at that time. We had an epidemiologist who was trained in Bulgaria as a physician and was really very happy to go out and do field epidemiology and go through every drawer and you know, every nick and cranny of the house. And so what was found? Well, this was what was found. Something called Sindor. You probably all know about it now. And this is used for making the bindi or the part in marriage ceremonies. And it's this beautiful color, but it it is known in Indian culture, in Hindu culture, as poison, and that most Hindus know not to use much of it. This actually, we examined various things that we found in the house, and the Sindor is what was found to be almost 60% lead. This led to a worldwide discussion of Sindor and the dangers of it. And I actually got called by the news media in India. I'm going to quit there. This is Mark, how do I quit and leave it open to questions at this point?
You can end your slideshow, Steve.
Okay, if I could figure out how to do that. Just close this, I guess.
Yeah, whatever you want. That sounds good.
Okay, all right. All right, well, are there any questions?
So, Steve, what are your you presented some 3 striking cases, I think, of cases that you were directly involved with. and your title of your talk was the physician's responsibility to report. So this last case doesn't really seem to me to fit that theme of a physician's responsibility to report, and it seems more like a testament to, as you mentioned yourself, your compulsivity and your adherence to tenacity and adherence to these type of cases. So what's the message here for our audience, especially with all of our young learners out there? What do you want people to get from these three cases?
Well, if I could go figure out how to go back to that the slide that I talked about on what you need to be, and you need to have a prepared mind, and you do need to have the knowledge, and yeah, all of your fellows and stuff are going through that experience now, and gaining the knowledge of what toxins can do. And the nice thing about these sessions that we have is that we tend to discuss some rather obscure poisons here that the rank and file physicians may not think about. So obviously that's always the first step. But you always have to keep in mind that what you're seeing, although you're always taught to when you hear hoofbeats, think horses. I say in our discipline, when you hear hoofbeats, think zebras, and you will be, occasionally you're gonna find yourself seeing those zebras, and to be compulsive. If you're thinking about something, go for it. Don't be shy. Be willing to take abuse if need be, to get to the bottom of what the case really is. And yeah, get help. Uh, don't have to do it on your own. On the Cullen case, you probably remember, I think you was there at the time. I presented it at a Thursday session. I think I presented that August actually, because so many people were arguing with me that it wasn't somebody trying to kill people, that I needed the reassurance from everybody else. And I mean, that came back to haunt me, if you recall, because the newspaper then got wind of the fact that I had presented it there. And, I found myself in the front page of the New York Star Ledger with the story that I had presented it at New York. And part of our, discussion on what people should carry away from the meetings should be confidential. But anyhow, so uh, use what resources you have, and I was even with the lead, I did have that resource. I had Dravko that was able to go out and help, and I did have some people from the Department of Health that were very helpful to us. That had we not reported and had we not screamed and kicked and what have you with the health department, we would not have been able to get into the house to do that kind of an evaluation. So they really are all examples of all of that. And, you're all capable of that tenacity, as you call it, or fervor, or, passion, whatever you want to call it.
Okay, I don't see any other questions. So I'm going to ask you one more question here, Steve. So
Sure.
your first case was struck a chord with me because you gave some information about reporting guidelines, and you talked about communicable diseases and disease and poisoning as an entity as something to report. And that strikes a chord with me because in New York City, as part of the health code, poisoning is
Yeah.
supposed to be reported to the Poison Control Center within 24 hours. And yet, despite it being part of the New York City health code, people are not aware of this. And we often think and maybe know that we get underreporting of cases to the poison center, the run of the mill cases to the poison center. So, what's your advice to me to improve reporting by the public and by healthcare providers?
Boy, I wish I had the answer to that. Mandatory reporting obviously doesn't work. Uh, these kinds of sessions, and let's at least deal with the group that we can deal with, and tox has become primarily a discipline in the emergency room. So, and the emergency room doc is the one in the front lines that is potentially capable of picking up a disease or an outbreak. I don't care whether it's tox or what have you. Let's switch gears a little bit. Right after 9/11, if you remember, there was the anthrax scare. Somebody actually published an article, and I can't find it. If anybody can ever find it, please get me a copy, where they showed that every day that the missing of the first case of anthrax, the geometric increase in potential lethal cases that would spread was just tremendous. And that would require that ED doc that sees that first patient to have the thought and the knowledge and the compulsivity to drive home and to report it and say, hey, I think I've got something. And I think that's a major take home, regardless of whether it's a poison or not. How are you going to? Most doctors don't want to bother reporting. That's the bottom line. They feel that it takes too long, and it may take too long, actually, to be honest. Hospitals now generally have infectious disease practitioners that help as far as the reporting of infectious diseases. I don't know of a hospital that has a toxicology reporting practitioner. That would be nice, but in our world, that's just not going to happen. I hope that all of the people that attend these sessions that work in hospitals have all of their tox cases reported to you all, because from an epidemiological perspective, you really need to have all the cases in a database and somebody reviewing that database to look for trends and clusters.
Okay.
I hope I didn't bore everybody. No, not many questions. That means either I did a very good job or a terrible job.
This is Mary Ann. Steve, that was excellent. And just communicating those important points at the end is the most important. Our young practitioners need to be curious. They need to follow things up to the conclusion so that they can see. And when there's something that's an anomaly, not just to brush it off, but to try and figure out what the answer is. So I applaud you for all of these things.
Thank you. You put that in better words than I. If I can push my book, get a hold of it. I mean, there are 14 such cases. I don't know how I accumulated that many, but to take a look at it. You can get it free through your medical library. Most of the libraries have subscriptions through Springer, and so you can actually read it without paying for it.
I agree with Mary Ann completely, Steve. Thank you for this talk. I just want to echo one comment to the entire audience that's listening today, is that reports to the Poison Center can be done by anybody. It can be lay people, it can be providers, anybody in the hospital can call the Poison Control Center at any time to ask questions regarding cases and to report them to us. And that would be very helpful because oftentimes, as Steve just mentioned, we're all faced with time constraints. We're all very busy. And reporting is just another thing that slows us down and detracts somewhat from our care for patients. And yet that responsibility, that the need to report this for epidemiology and for the cases that Steve mentioned and how to detect these kind of strange cases is very important. That ultimately affected a lot of people's outcomes. So thank you very much.
Thank you.
I think we have one question.
Okay.
Diane Colello, you're there, Diane?
Yes, I am. Can you hear me?
Yes, yeah, Diane, please. Go ahead.
Happy New Year, everyone. And
Happy New Year, Diane.
Thanks so much, Steve, for a great talk that, just reminds us of so many things we're proud of in the NJPI's history, but also I think of the importance. I often think of our field of toxicology as one like full of rabbit holes, right? There's always some place to dive into and investigate. even if it's not the medicine, it's just the situation behind the case, and figuring out the pathway to injury and how it happened, and that intellectual curiosity that you obviously have and champion has made a very big difference. So I thank you very much for the summary and taking us through those. I do have just one comment on the reporting issue, which is, I've thought a lot about how we could lower the barriers to reporting through poison centers. And we've talked about it a bit in this context before. For the run-of-the-mill poisoning, maybe it's a web form or, something that doesn't put so much burden of picking up the telephone and calling. Because I think we know that a lot of people really don't even like using the phone and making calls. And I'm open to anybody's suggestions on that. I've thought, of course, we want to provide our advice, but is there a way to lower the hurdle to reporting cases for an epidemiologic purpose, et cetera?
You're in a kind of an in-between population. My grandchildren that don't like using the phone at all. I mean, they
Right.
are attached to their mobile devices and do everything through that. And I guess eventually we're going to have to figure out. I mean, I will never get to that stage. I can't even type anywhere. The speed that, I mean, they amaze me when they do it. But
How to join WebEx though, Steve? You're an expert at WebEx.
Yeah, but you're right. We do have to figure out a way to bring the younger population into this. It'd be a shame. I mean, what sets the human away apart from the great apes is our ability to communicate, and I talk about that communication as verbal, not with pushing buttons. But it's a conundrum.
Yeah,
You're
for
right.
sure.
All right, perfect. Thank you very much, Diane. And again, thank you so much, Steve. We really enjoyed that lecture a lot. All that experience has been amazing. And thank you for sharing that with our audience. Okay, we're just going to take a 2-minute break. Actually, not even a break. We're just going to transition to the main conference. Okay, so Zach, you want to pull us up?